So first of all, I'm really thrilled at how many of you are here today. It's just so wonderful to see so many friends and family, as it were, of this place joining us today to really talk about the history of HIV and AIDS, both in Rochester and really nationally and internationally. So first of all, thank you all for coming. It's just wonderful. The next thing I wanted to say, obviously, is we're all here really to listen to Dr. Gottlieb. He has a wonderful story to tell you, and I'm not going to trample on any of his storylines, but just it's a very engaging story of, being a young physician and discovering a new disease. It's really such a privilege in many senses to be in that place. Before I go too much further, I also wanted to acknowledge a couple of groups or individuals who've really helped us this evening. In particular, I wanted to sort of shout out to Evelyn in the Gay Alliance of Genesee Valley, is one of our co-sponsors of this event. Thank you. I also wanted to acknowledge the posters that you saw a moment ago. Those were donated to the university, the library system, by Dr. Edward C. Atwater, starting in 2007. And I'm sure you saw there are really a whole range of just terrific posters. They engage all sorts of different population groups. Some of them are very funny. Some of them are really very political. And they're a wonderful sort of memorial, if you want, to the history of this disease and the history of fighting this disease. I also wanted to give you a little bit of a teaser in terms of what we'll be talking about this evening. So one of the things we'll be talking about is the history of HIV/AIDS research here at the University of Rochester, and that has a 30-some-year history. Many of the people who played a pivotal, foundational role in that are in the audience today, and Mike Kiefer will really go through that and give you a sense of really what a long and really distinguished history we've had here. And then we also want to talk more sort of currently about what's going on. So one of the things that we're very excited about and pleased about is that we've recognized as a Center for AIDS Research by the NIH. So we started as a developmental center in 2008, and then we graduated to a full center, if you want to look at it that way, in 2013. And that's really down to the quality of the science that's done here, and that's a recognition of our faculty, our students, our staff, and our fellows. So that's just a tremendous recognition of the place. I want to also give you a sense of some of the projects we're really focusing on, and some of that was in the handouts out in the lobby. So there are two particular projects that we are very excited about. One of those we'll talk about in the panel discussion period, and that's Handy Gelbard's work. So he's really engaged with developing a first-in-class, first-in-human therapy for the neurologic aspects of AIDS, which really remain a huge problem. So if we think about AIDS as a disease, or we think about HIV as an infection, we have very good drugs that allow people now to live essentially a normal lifespan, but there are other aspects of the disease that those drugs don't treat, and one of those is the neurologic aspects of AIDS, and I think in the panel discussion we'll have a chance to explore that with Handy. The other piece we want to talk about is in the developing world. In the developing world, there are many opportunistic pathogens that remain deadly, particularly fungal diseases, which turn out to be very neglected. And there's a particular fungal disease, cryptococcal meningitis. That disease kills as many as 500,000 people worldwide on an annual basis. And one of our infectious disease docs is really very engaged with that disease. So that's the other sort of major focus that we have within the CFAR, what we'd really like to see achieved in the next 5 years. So tonight, really, I want to focus our attention on Michael Gottlieb. We're really tremendously grateful. He's been a wonderful friend to the institution over many years, said all sorts of very gracious things about the place on the radio today, for those of you who had the chance to hear the thing on XXI. So with that, Michael.
Thank you. Thank you very much, Stephen. And thank you. Back when I was a lowly medical student here, which was 1969 to 1973, I couldn't possibly have imagined a program entitled An Evening with Dr. Michael Gottlieb. So that's just great. And it's always wonderful to be back here. It's actually an honor to be speaking at the University of Rochester, where I was very fortunate to receive my medical education, to see colleagues here who were my teachers, Dr. Chesson, Dr. Brown, Dr. Betts, Dr. Valenti, and others, I'm sure, who are in the back rows. just to see these folks again. Being here brings back lots of memories. Slogging through long lectures in Whipple Auditorium, escapades at Helenwood Hall. I had my 40th class reunion some years back, and it was really great to see some of the wonderful people I went to medical school with. And also, I was very fortunate to be one of the dullest members of the house staff program here, which during my time just had remarkable people in the Department of Medicine house staff program, and I'm sure it still does. So I'm very pleased to join this distinguished panel of faculty members tonight. I guess I get to moderate. And it focuses on HIV research done here at the university. The University of Rochester has a world-class program in HIV research. It's internationally well-known, and it has an amazing track record in the field of HIV, which goes back to the early 80s, as Steve told you. Also, the University of Rochester has an amazing record in vaccinology, which of course is the development of vaccines, going back to Dr. Smith with HIV, Haemophilus influenza type B, influenza vaccine studies, smallpox. There's a smallpox footprint with Dr. Henderson, and most recently the HPV footprint. So the university, I think, medical school is really well positioned to continue to play this important role in HIV prevention, hopefully in the long run through a vaccine. So as an alumnus of the medical school and a house officer here, it's something I'm very proud of to be associated with this university. I think tonight's program is going to be very informative. It's going to be informal. We're hoping to get some contributions from the audience because we know that you have some great questions out there for our panel. And so I've been asked to say something about my story, so I'll segue into that, about how I got credited with discovering AIDS in 1981, just 4 years after finishing my residency. Some years ago, I gave a talk here in which I said, I'm certain that my faculty members here were shaking their heads how it could be possible that this particular student did that. And then Dr. Marshall Lishman, who turned out to be dean at the time, came up to me and said, you know, Mike, you're absolutely right. But I do remember, putting micropipettes up to white blood cells in Dr. Lishman's lab, as a first-year student. And while I wasn't really great at it, it gave me an appreciation of what basic science was about and the commitment and the kind of technology that it took and the patience that it took to do good science. And while in the long run, I made my mark in more clinical medicine, I have a great appreciation for the power of science and what science can do in a disease state like HIV. I think most of us here tonight appreciate just how much progress has been made in HIV through good science. So 4 years after finishing my residency, I was at UCLA. I had left Rochester in the summer of 1977, and I drove an old car cross-country equipped with a CB radio. And that was in order to hail various truckers on the way. That was the culture back in the late 1970s. And I can't recall whether I ever was successful in having conversations with the truckers. But I headed west to do an immunology fellowship at Stanford. I had given very serious consideration to staying here because I really liked it here. Carl Oshrain, who's an internist in the community, had offered me a job. And John Condemi, who's an immunologist here at the university, was really a very magnetic figure, a great teacher. And when I told him I was going to Stanford, he said, well, Stanford's a very good program, but they don't have me. And there really was a lot of truth in that. I never met someone as wonderful a diagnostician as John Condemi. So I stayed there for 3 years, and I was mostly in the lab, working with mice and rats, as my wife likes to point out, and doing organ transplantation, trying to overcome the major histocompatibility barrier. We had a technique called total lymphoid irradiation for suppression of the immune system, and we thought that it might be useful for creating an environment where bone marrow transplants would engraft easily and be tolerated by the host without rejection. So there I worked with Dr. Henry Kaplan, who had made his mark in Hodgkin's disease. So when I finished up there in 1980, there were no positions available on the Stanford faculty. So at that point, I jumped on the freeway, as we say, in Los Angeles. I jumped on the freeway and headed south, several hundred miles to Los Angeles. Now that was over the objections of many of the Northern Californians who I knew, who said, how could you possibly go down there and live with those people and be part of that culture? I mean, people down there, they take their eye off the ball. They're not serious about medicine and or much of anything else. And so they had a very strong opinion about Southern California. So I did go down there, and I took my first real job at age 33 at the UCLA Medical Center, and in the Division of Immunology, Department of Medicine. I brought my mice with me, or rather I shipped them ahead of time. In a nice box, I packed them myself. I left them potatoes and water to dine on in their journey. And they made it to UCLA, but unfortunately didn't survive much beyond that because of pathogens in the mouse room. And so my mice didn't make it. And there I was with a new job. And I had started a lab, and I tried to continue that transplant work, and I taught students and fellows. And I had had great teaching here, and so I really always was committed to giving back and trying to instruct students. And so in the course of doing that, it's where in January of 1981, I saw my very first patient with AIDS, with a disease that would later be called AIDS. And he had this lung infection, pardon me, a lung infection called pneumocystis. And at the time, this was extraordinarily rare in the United States. It was an organism that caused illness only in people whose immune systems had been suppressed by chemotherapy or radiation therapy, or in the course of transplants. And I recall considering pneumocystis in a differential diagnosis here at Rochester during my residency with Dr. Art Baumann, who was one of the oncologists. And it was a patient who had had radiation therapy for Hodgkin's disease, and she developed a pneumonitis, a lung inflammation. And we were listing the various things that could have caused it. And one of them was radiation pneumonitis, and the other one was pneumocystis. That was the only time I had ever considered it seriously in a differential diagnosis, and this young woman turned out not to have it. So it was just striking to see this first person with AIDS at UCLA, a 33-year-old gay white man who had lost 25 pounds, had fevers of unknown origin, had thrush, a yeast infection of his mouth, and had these florid pulmonary infiltrates that were due to pneumocystis. And the way I found him was by sending the fellow to the medical floor to just find a case with immunologic features that might be interesting to talk about on rounds. And he came back and brought back this first patient with AIDS. So pneumocystis at the time was shocking. It was just a striking finding to see this infection in someone coming in off the street without a history of immune suppression or chemo or organ transplant. It was really not a subtle disease at all. This was a seriously ill patient. And I thought at the time that he might be one of a kind, that I would never see another patient like this. And within the next 2 or 3 months, 3 more patients were referred. And all gay men, all with fevers, weight loss, the classical presentation of AIDS as we know it today. So in the laboratory, we studied up the immune cells, and we found out that this very important cell of the immune system, the CD4 T cell, was essentially absent in these 4 patients. Now, back in 1980, CD4, CD8 was an experimental test. Today, the medical student or intern sort of scribbles off or types into the computer orders T-cell subsets. But back in 1980, this was still a research test. And we're very fortunate to work close to a laboratory that was testing these new monoclonal antibodies that measure, that enumerate the CD4 and CD8 cells. And we found that the CD4 cells were essentially missing. And these cells, of course, have been called by Dr. Tony Fauci and others as the conductor of the immunologic orchestra. A cell just critical to the coordination, overall coordination of the immune system. So at that point, I thought it was a hot story. It seemed that this could be something very interesting, very new. And so my first reaction as an ambitious young investigator was to get on the phone to the editor of the New England Journal of Medicine, which is probably not necessarily the natural course of events. So I picked up the phone and called the New England Journal of Medicine, and remarkably was put through to Arnold Relman, who was the editor, also known as Bud, his nickname. And he was a longtime editor of the journal, and he took my call. He's a nephrologist, a kidney doctor. Took my call, and apparently he gave it some sort of credibility. I told him we had these patients, described what we had seen, and he asked a very pertinent question. Have you called the CDC? And as someone who was an immunologist by training, it truly hadn't occurred to me, despite Dr. Bett's instruction here in medical school. And despite my many classmates who read the MMWR on a regular basis during medical school. Hey, did you see what was in the MMWR this week? I say, what? What, MMWR? Because it used to be this little newsletter that wasn't very attractive, but it did report what was new and exciting. And so then I said, well, that seems like a good idea. And he also said, if you write a report for MMWR and they accept it and print it, we will not consider it subject to what's called the Ingelfinger rule. Now, I see a querulous look here in the front row of Dr. Gelbart. The Ingelfinger rule came from Hans Ingelfinger, who was an editor of the journal at one time. And the rule is that if you leak anything about a new finding or you publish it elsewhere before it appears in print in the journal, you will never publish in the journal again, basically. And so what Dr. Relman was saying was if the CDC publishes your cases, we will still consider them for publication as a full article in the journal. And in fact, he made good on that. And later that year, we published the cases in great detail, including the T-cell subset information in the New England Journal. So on June 5th, 1981, backtracking just a little bit, CDC published our report, my report, in the MMWR as the second paper in the issue. It followed a report of dengue fever among American travelers to the Caribbean, coming back with this viral disease, dengue fever, which Dr. Dewhurst was saying earlier today. We can talk more about it on the panel, may migrate northward with global warming. So it is important 30 years later. Just kidding. But in any event, so pneumocystis pneumonia Los Angeles was the second article in which we described our cases and wrote a commentary. And that is taken as the first report of AIDS as a new disease in the scientific literature. And CDC, in fact, dates the onset of the HIV epidemic for purposes of counting cases as June 5th, 1981, the date of that publication. So it's technically the anniversary of the HIV epidemic. But of course, we know now that HIV was present in North America well before 1981. In fact, retrospective studies of frozen blood specimens indicate that it was here at least as early as 1977, although not in large numbers. And it may have been here in the 60s, based on genetic studies of viral isolates. So AIDS as a new disease came about in 1981, but in fact HIV, the virus that causes it, was here years earlier. Well, my excitement of having made a new discovery, and it was very exciting, it was quickly tempered by a realization of just how ill these patients were. Our first patients had pneumocystis and then one opportunistic infection after another. Their immune systems were essentially gone, and they fell prey to multiple opportunistic infections and to deforming Kaposi's sarcoma, which we saw soon after that. At first, I thought that the immune deficiency in these patients might actually be reversible. We speculated that, well, our first 4 patients were gay men. Is it possible that they had some common exposure to a drug or to a toxin that might explain it, and that their immune deficiency state might be spontaneously reversible? It may have been certainly a naive consideration, knowing what we know today, but back then, seeing those first patients, we thought that that might be a possibility. Of course, 2 years later, in 1981, French researchers at the Pasteur discovered the virus, which we now call HIV, generally recognized as the cause of the advanced immune deficiency state that we know as AIDS. So back then, in the early 80s, we were starting from scratch. We really had no information. There were wild theories about what might cause this. Early on, we did consider the possibility of a viral etiology, because the epidemiologic pattern certainly looked a lot like type B hepatitis. Same groups, after a couple of years, the same groups affected more so than others were the same groups at risk for type B hepatitis: transfusion recipients, hemophiliacs. Gay men have an increased risk of chronic type B hepatitis, and I'm probably missing 1 or 2, but essentially the same groups. So I remember those first patients in great detail. This was striking. I remember what they looked like. I remember certain mannerisms of those first patients in far greater detail than patients I saw last week, because these patients were so unique. And I remember the courage with which they faced the unknown, and how they never held us to any standard of, why don't you know what I have? Why don't you do something to fix me? We were all in the dark at the time, sort of just feeling our way along. And these patients were remarkably considerate of the frustration that they saw in their doctors. And their partners and parents, I remember them well. A few years back, I was standing in the grocery line at a store in the San Fernando Valley, And someone came up to me, tapped me on the shoulder and said, "Hi, Dr. Gottlieb, do you remember me? I was Chuck's lover." And Chuck was our second or third patient with AIDS. A fellow from Oregon who raised finches, his hobby. And what this man said was, Chuck's and his mother, who used to come down from Oregon, they just so appreciated, how you tried and what you did for him, the second or third patient with AIDS. And so, ultimately unsatisfying in terms of patients dying of AIDS, it was rewarding work. Well, about 3 years after my first report, almost to the day, I got a call from a Beverly Hills dermatologist about a celebrity with AIDS. And would I come out to this woman's office and see an actor with AIDS? And that actor turned out to be Rock Hudson. Of course, Rock's going public with his diagnosis in 1985, and then I think just last month is the 30th anniversary of his death from AIDS. Rock's going public is considered a milestone in the HIV epidemic. Randy Schultz, in his book, And the Band Played On, talks about AIDS pre-Rock Hudson and AIDS post-Rock Hudson. Because prior to Rock Hudson, 3,000 or 4,000 people in the United States had already been diagnosed with AIDS, and yet there's so little recognition of that among the public in general and among the federal government in terms of providing support for research and studying the new disease. But after Rock Hudson, there began to be a push toward HIV research. And all sorts of studies were generated in that period of time. The AIDS clinical trials groups dated, or at least the seeds of starting them happened in those years, and the natural history of AIDS study, the sequential study of both HIV positive and HIV negative gay men, working out the natural history of the viral infection, started in those years. And that's because federal funding was finally forthcoming, and that was all after Rock Hudson's diagnosis. So that's around the time I met Elizabeth Taylor, who was his good friend. And ultimately, together with Dr. Krim in New York, we started the American Foundation for AIDS Research, which you all know as AMFAR. So all this time, I was still trying to go the academic route. In 1986, I was the PI of the AIDS Clinical Trials Group at UCLA, very much like the one that was awarded to the University of Rochester that same year. But my days in full-time academia were numbered, in part due to the hubbub and publicity around Rock Hudson, and my role in starting AMFAR, which was seen by the university as a conflict of interest in terms of fundraising. And so at that time, I transitioned to the voluntary faculty, the clinical faculty, and that's where I've stayed ever since. And I've taught medical students since that time, trying to channel my teachers here at Rochester, George Engel and Bill Morgan, albeit unsuccessfully. Limited success, let's say. And so that brings me around to the program tonight, focusing on the research here at the University of Rochester, research that promises major new advances in HIV care. Before I do that, I do want to say a word about World AIDS Day, December 1st, which is just around the corner. It's the 1 year every day. It's a 1 day every year. This is limited sleep, spending the night at the Detroit airport, not at a hotel. This is the 1 day a year when the world's energies, the population of the world, thinks about HIV/AIDS, because these days it's hard for us to get a sound bite. And it's good that at least 1 day a year we have this opportunity. So everybody think about World AIDS Day and get out your red ribbons. I don't see too many red ribbons, AIDS ribbons, around these days. And if you all get them out, perhaps we'll get a little more attention to what still is this very